Hi guys, this is Beverly. We have quite a heavy week this week. Even though it's a short amount of reading, it's a lot of information. So I'm going to try to keep everything fairly short and concise, and hopefully the points will get made across. We're going to start first with a review of electrolyte and acid-base balance. So we know that our body has to have a balance between the level of fluids and the various chemicals within our body, and there are fluctuations both in intake and output, and if there is too much of a fluctuation it causes a destabilization, and that there is an equilibrium that is in our body related to acid and alkalinity, and we consider this to be the acid-base balance. So we know that our body is in a constant state of homeostasis. It has the ability to self-regulate to keep this balance in present, and the body itself works to keep an internal consistency. We can, however, have fluid imbalances. We can have excessive fluid loss or fluid deficit. This is a decreased circulating volume, and that has a direct effect on the cardiac output. We can also have a fluid volume excess, which is an increase in that circulating volume and therefore increases the workload of the heart. And this is just kind of a schematic of how homeostasis is maintained. You can see all the organs that are involved and how that all works. And if you review your anatomy and physiology and pathophysiology, this should just be a simple review for you. We know that there are normal structures, that the composition of our body fluids, we have our total body water, which is the percentage of weight that consists of water. We do need a sufficient amount of water in order to survive. Approximately 60% of an adult's weight is kind of water or fluids, and these can either be intracellular or extracellular fluids. We know that body fluids are composed of both water and solutes. So just you see the definitions of solutes, crystalloids, and colloids, and that we know that solutes are the electrolytes and non-electrolytes such as proteins, oxygen, and glucose. And we know that electrolytes have a charge on them, and that is what helps conduct electrical impulses across the cell membranes. We know that we have movement processes of body fluids. We have osmosis, osmotic pressure, osmolality, and osmolarity. So just review these definitions, and if you need to refer to them as we use these terms throughout the lecture, you'll have them right there for yourself. So this is just a picture of osmosis. I'm sure you're all familiar with this, about how things move. Water and dissolved substances move across a semi-permeable membrane. We know that there's tonicity, which is related to the level of osmotic pressure, and our osmotic pressure in the intravascular space is really controlled by the presence of our plasma proteins. And this is just kind of what happens to the cell when we give them a hypotonic solution, a hypertonic solution, and an isotonic solution. So the column before is before the solution is introduced, and what you see in the after is what happens within the cell after the solution is introduced. We know that there's a process of filtration, which is how fluids and solutes move together to areas of higher concentration. There's hydrostatic pressure, which is the force of the fluid against the blood vessel. And then we know that fluid balance is influenced by the opposing forces of both hydrostatic and oncotic pressure. And this is just a diagram within a vessel and within the outside of the vessel to kind of show you how that dynamic process takes place. We know that we need to maintain adequate volume, and we have to balance our intake and output. Most of what comes into our body is through foods or fluids, and primarily water is lost either through the kidneys and it's excreted as urine. So we know that this is just kind of an average chart to kind of show what we take in and how we kind of put it out. And excessive loss or intake is what results in either hypo or hypervolemic states. These are osmoreceptors, which we know help tell us when we have too much plasma volume or it's too concentrated. So just kind of review this chart. So there's movement of electrolytes. They come in and out of the intracellular and extracellular spaces. This can happen by diffusion, filtration, or active transport. We also know that we have facilitated diffusion and then active transport. So this is just a diagram of just our basic diffusion, how if we have things in a higher concentration, they will move to areas through a semi-permeable membrane to an area of lower concentration. We know that our body maintains an acid-base balance, and so in order to have optimal metabolic function, thus pH of our tissues and blood need to be in a range of 7.35 to 7.45. We know that that is slightly alkaline, but that is the pH that is required for our body. And we know that an acid is a chemical that can release hydrogen ions, and we know bases are substances that accept those hydrogen ions. We know that acid-base balance is regulated both by the respiratory system and the renal system. And the diagram off to the side of the thing is just a schematic of how that is done within our body. So we know that what the kidney function is here and what our respiratory function is. We know that we have buffering systems. We have the carbonic acid bicarbonate buffering system. It's the primary buffering system. So we know that there are imbalances of our acid base. We know that when our acid or base are imbalanced, we have two compensatory mechanisms that kick in. We can either have a renal or a respiratory compensatory mechanisms, and they're designed to help return that acid base level to within that 7.35 to 7.45 range needed. There are four imbalances that can occur: respiratory acidosis or respiratory alkalosis, metabolic acidosis or metabolic alkalosis. Respiratory acidosis is caused by a decrease in gas exchange. We have hypercapnia or elevated CO2 levels. The renal compensation for this focuses on excreting excess metabolic acids, and it wants to conserve the bicarbonate in order to raise the pH. Respiratory alkalosis can be caused by hyperventilation or excessive exhalation of CO2. Our renal compensatory mechanism with respiratory alkalosis is focused on preserving our metabolic acids, and it wants to decrease the amount of available bicarbonate. Metabolic acidosis occurs when we lose bicarbonate ions or an increase in acid produced by byproducts of metabolic processes. And when we have a metabolic acidosis, we are going to increase our respirations in order to blow off CO2 to help compensate and bring the pH up a little bit. Metabolic alkalosis occurs when there's an excessive intake of bicarbonates, and that can be medications, loss of gastric acids, nasogastric suctioning, and possibly frequent blood transfusion. And the respiratory system compensates this by holding on to CO2, slowing our respiratory rate down so that we blow less CO2 off. These are some normal ranges for our electrolyte levels. And note that this is from your textbook, and a different textbook may vary slightly in these, but these are a good reference to have. So we know that sodium, it's in the extracellular fluid. We know it's regulated by antidiuretic hormone and aldosterone, and that it's a primary regulator. And it helps with osmotic pressure, mainly excreted in the kidney. And it has a role in transmission of neuromuscular impulses and cell membrane potential. Hyponatremia is sodium levels decreased in relationship to body water. Hyponatremia, sodium levels increased in relationship to body water. So that would be elevated within those normal ranges or below the normal range that I gave you. So this is just a picture to show you some of the causes, what some of the symptoms your patient might experience, whether they are hyponatremic or hypernatremic. So this is a good reference to go to when you're thinking about if my patient has some off-balance electrolytes, what I might see in my patient. We know that potassium works with inside the cell. It helps maintain osmolarity and electroneutrality. It has a direct effect on our cardiac muscle. It does have a role in acid-base balance, and it helps with conduction of nerve impulses. So we can have either hypo or hyperkalemia. Slight imbalances in either direction can affect the cardiac and neuromuscular functions. So hypokalemia is defined as a potassium level less than 3.5, and hyperkalemia is defined as a potassium greater than 5.0. Again, this is just another picture that I found to help kind of show you some of the causes and then what you might see in the patient as far as symptoms. Calcium, it's plentiful. It's stored in bones and teeth. It's necessary for bones and coagulation. It helps with neuromuscular activity, and it's very critical in the myocardial muscle, and it helps aid in action potential. Again, I put on another thing for you to show you some of the causes of hypoglycemia, hypocalcemia, or hypercalcemia, talking about calcium here, and what the patient's symptoms might look like if they were having either one of these conditions. So magnesium is another electrolyte, mainly in the intracellular fluid. It helps with cellular activation. It works with protein and carbohydrate metabolism. It activates the sodium-potassium pump, and we need it to help maintain our calcium levels within the cell. So you can see what the definitions of hypo or hypermagnesemia is. And again, I found another great little picture of what some of the causes are of hypomagnesemia and hyper, what the patient's symptoms might appear to be like. And so if you would like actual page copies of these to put in your notes, just let me know when we come to lecture, and I'll figure out a way to get them to you by the next Monday in lab. So then there's phosphorus, which it's in the intracellular fluid. It has a role in our bones and teeth. We know that it's necessary for metabolism and production of and storage of ATP. We know that we need it for nerve and muscle function, and we know that phosphorus also does help with acid-base imbalances. And here, not such a nice little picture, but a flow chart of hyper or hypophosphorus and some of the causes and what some clinical manifestations you might see with patients who have these particular electrolyte imbalances. So we can also have fluid volume deficit, which or hypovolemia, when we have an excessive loss or an inadequate intake. We can also have fluid volume excess, in which we take too much in, and we often see the development of edema, which is the abnormal accumulation of fluid in the interstitial space. This is just kind of a flow chart of the mechanism of how edema is formed. So that's just for your own knowledge to see kind of how the different pressures and the capillary permeability and the oncotic pressures help or influence the formation of edema. So we also know that when our serum albumin is low, it changes the hydrostatic pressure. And then that also allows fluid to seep into our interstitial spaces. And so we may appear to have fluid volume excess, such as weight gain, pulmonary congestion, but in our vascular space, we actually see a fluid volume deficit because the fluid isn't in the vascular space, it's actually in the tissue. So, some diversity things to consider would be the lifespan when you look from infants to elderly, that they're just different things that they're more susceptible to based on the percentage of body water that they have to other parts of their body. Gender, you might see changes related to hormonal function in women, and men tend to have a greater total body water percentage.